Hi, everyone. Thanks for joining us today. I'm Denise Wilson. I'm going to be your host and one of your presenters. I have Dr. Kendall Smith with me also here. I'll do a formal introduction here in just a minute. So glad to see you all here today. Man, we had a huge turnout for this one, so we're excited to present it. We've been talking about it for all week, getting prepared, and we're kind of excited to see what's going to happen with Medicare Advantage and the Two-Midnight Rule in 2024. So we want to give you our best guess, our best predictions, having studied about the rule and hearing from the community about what you're seeing so far. We want to give you a way to prepare for the coming changes that will occur after the first of the year. So I hope you all will go away from this today with some ideas, some thoughts, some plans, some education on what we're going to see in the changes after January 1st. So this is the Association for Healthcare Denial Appeal Management. This is our complimentary Wednesday webinar, and glad to have you with us. If you are not familiar with our platform, you should have a control panel that has popped up with your webinar. And from that control panel, you can select if you're going to use computer audio or call in. It'll give you a phone number. You can download handouts from there. Now we have the handouts of the slides for today uploaded there for you. We also have, as a bonus, we have given you an appeal letter template that has some language in it to use after the first of the year for your Medicare Advantage denial. So please take advantage of downloading that and using that going forward. I'm not going to go through the template. If you've not seen any of our templates before, we have done webinars in the past on the templates. I believe if you want to watch our past webinar on the anatomy of an appeal letter, that will walk you through how to use the template that we're providing for you today. But we just wanted to offer that as a little bonus for the presentation today. You can also download the handouts at our website at www.ahdan.org. I know sometimes you have difficulty downloading from GoToWebinars because you may have firewalls and things in place if you're watching from work. If you have questions for Dr. Smith or I today about the topics, please submit them in the questions bar, and we will do our best to answer a few of them. We will try to leave some time at the end to answer those live. If we don't get to them live, what we typically do is we will draw up a document with questions and answers, and we will post that on our ADAM website, usually within a couple of weeks. Give us a little bit of time to get through your questions. And I'm guessing we're going to have a lot of questions today. That's just my prediction. CEUs, if you're attending this live, you can obtain CEUs if you are an ADAM member. You have to be on the live webinar for at least 53 minutes, and yes, we do check that, in order to get your CEU. The survey to get your CEU will pop up automatically for you at the end of the webinar. You fill that out. It's a short little survey, answer a couple of questions. The CEU certificates will then be emailed to you, usually within about a week of the webinar. They're not available for watching the recording of the live webinar, and I do need to disclose that there are no individuals in a position to control content for this activity that have any relevant financial relationships to declare. When you do the survey for the CEUs, you can select as many of the CEUs that you'd like. We have them for ACTIS, NARI, CCMC for our case managers, AHIMA, and ANCC for our nurses. And I'm really excited to announce that we are going to be doing a virtual winter workshop in January. We're very excited about that as well. So, what else do you have to do in January? The holidays are over, right? Come visit us and see us on the web as we present our first virtual winter workshop. Early bird registration is now open. You can register through our website. I've got the URL there. There's an early bird discount available through December 15th. The workshop is going to be available live, but also on demand. If you can't attend live, you can still register and attend on demand after the live webinar workshop, which is January 23rd through February 2nd. We have 4 different tracks: medical necessity, coding, clinical validation, and revenue cycle. Sign up for as many tracks as you'd like, and we hope to see you there. About the association, we are the nation's only association that was developed to support those of you who are working in denial and appeal management. And it really is our mission to provide education, support, collaboration, and advance those who are working in this field to being recognized as a specialty. So that's our goal as well, is to create this as a specialty area for those of us who work in trying to prevent denials and be successful in our appeals. And it was created through the generous support of Payer Watch. Payer Watch has 2 service lines. One is Appeal Masters, where Payer Watch provides appeal services for hospitals who need some extra support in managing your appeals. And then Payer Watch also has a software for denial and appeal management called Veracity, and it is a leader in the industry in denial and appeal management software, and it is there to help providers protect their revenue. I do have to read through this disclaimer as well. The Association for Healthcare Denial and Appeal Management publishes and distributes materials on its website that are created by our members or invited industry subject matter experts for the benefit of all of our members. We don't certify the accuracy or authority of those materials. The materials are distributed and presented as research information to be used by our members in conjunction with other research that you deem necessary in the exercise of your independent professional judgment. We claim no liability in relation to reliance on the content of these materials. The views expressed are the views of the material's authors and do not necessarily represent the views of the association. References are provided for informational purposes only, do not constitute endorsement of any sources, and we have no conflicts of interest to declare. So as I said, we're going to do our best to let you know what we think we're going to see after the first of the year, but no one really has that crystal ball to see just how our managed Medicare plans are going to be behaving. So I'm Denise Wilson. I'm a Senior Vice President at Payer Watch, and I'm the President of the association. I've been in healthcare for well over 30 years, been doing appeal management and appeal writing for about 20 years now. Do a lot of education, a lot of talking about this particular topic, and I work with a great group of professionals both in the association and at Payer Watch, one of which is Dr. Kendall Smith. So glad to have him here today. He's a senior fellow in hospital medicine. He currently acts as the chief medical officer for Payer Watch and Appeal Masters. He's a leading appeal educator and appeal services. Payer Watch is a leading appeal educator. You're a leading appeal educator as well, Kendall. And appeal services firm for hospitals and health systems. He's been deeply involved in denials and appeals management throughout his hospitalist career. He has served as a physician leader on hospital revenue cycle management teams while also serving as physician advisor for clinical resource management. He's an AHIMA ICD-10 PCS approved trainer and ambassador, and he can talk about this all day.
I was going to say I was deeply in denial, and I'm like, I've been before, so yeah, I'm not a nihilist, but thanks to.
Okay, so our learning objectives for today, when we're done with the webinar, you should be able to summarize at least 2 major provisions of the Medicare Advantage and Part D final rule, which we're going to talk about, and how to prepare for the implementation of the final rule, how to provide feedback regarding MAO noncompliance. We're going to talk about that today as well. So these are the questions that are going to be asked on the survey at the end. The ability to identify 2 major provisions of the rule that have impact on our work, the ability to identify 2 steps to take now to prepare for implementation of the final rule, and 2 ways to provide feedback regarding MAO compliance. Okay, so let's get started with the good stuff. So just a quick overview of the final rule and kind of how it came to be. There was an OIG report that was issued in February 2022 that talked about Medicare Advantage organizations and their concern over whether the behavior of the MAOs was really restricting beneficiaries' access to services that they would have been provided had they been in traditional, had traditional Medicare coverage. And so then in August, CMS, they say it was mostly in response to the OIG report, although I know this is, again, my personal opinion. I know they've been hearing from those of us in the industry for a long time about MAO behavior, but either way, they finally in August of 22 came forward and said, okay, we want to propose a rule that puts a little bit more oversight on the MAOs and how they're behaving. We want to help clarify for the MAOs what they're supposed to be doing as far as providing services to the beneficiaries. And they asked for comments on the proposed rule, and they got almost 4,000 comments submitted. So there are a lot of people in the community that were very interested in telling CMS how they felt about this issue. Then in December of 2022, CMS issued a proposed rule. They published that. And then in April of 2023, they issued their final rule. So it went pretty quickly for anyone who's worked in the CMS arena for a while. That's pretty fast for them to put out a proposed rule, publish a proposed rule, and then issue a final rule. So when they issued the final rule in April of 2023, they said the effective date was June 5th. But the applicability date was January 1st, 2024. So there was some not really clear when they really wanted this proposed rule to go into effect, but the MA plans took the tack that, it doesn't go into effect until January 1st. So that's kind of where we are with that. So I don't think there's any way of backing off from the January 1st implementation deadline. So the final rule, and this is important, this reaffirms, okay, reaffirms. Okay, so there really isn't, there's very little in here that's actually new. It's almost all just reaffirming that this was what CMS meant all along when Medicare Advantage was created. So the final rule reaffirms that MAOs cannot limit or deny coverage for services that would normally be covered under traditional Medicare. It reaffirms that the inpatient-only list applies to MAOs. And it reaffirms that MAOs must follow the Two-Midnight benchmark as well as the case-by-case exception. And I think the inpatient-only list and the Two-Midnight benchmark are the two biggies that a lot of us felt MAOs should have been following and haven't, and have basically told us we don't have to do that. And Medicare is saying, yes, you do. And they're also saying that was their intent all along, that's not, of course, what we've experienced or what we've been told by the MA plan.
I think some of the other things that came out of that, Denise, that were striking was Medicare really reiterated that the MAOs couldn't be, for lack of a better word, re-engineering decided coverage issues, NCDs and LCDs. They couldn't go back and redesign them or change them. So in areas where Medicare's come out with published criteria, NCDs, LCDs, policy bulletins, those are to be hands off to the MAOs and have to be complied with. So it was really striking the way that the final rule actually mirrored everything that was in the proposed rule, and it was telling that they dropped the final rule between Christmas and January, I think, while everybody's back was turned and they were on vacation. This thing popped out, and it took a lot of folks by surprise. So I think the goal of this is real transparency, is what we're hoping to see from it.
So just to go over kind of quickly the two-minute benchmark, the case-by-case exception, I always like to start at the beginning because we a lot of times get folks on these webinars that are new. to denial of appeal management. So the 2 midnight benchmark, and this is quoted straight from the final rule and from Medicare regulations, is that it's stating that the inpatient admission is generally appropriate for Part A payment if the physician admits a patient as an inpatient based on his expectation that the patient will need hospital care that crosses at least 2 midnight. So that's kind of the crux of the 2 midnight benchmark. So the physician has to say, is this patient going to stay? Are they going to need hospital care for at least 2 midnights? Then I should admit them as an inpatient. Okay. The case-by-case exception, which was clarified in 2016, stated that Medicare is going to allow a case-by-case exception for inpatient admissions that don't satisfy the 2 midnight benchmark if the documentation in the medical record supports that the admitting physician determines the patient requires inpatient hospital care, even despite an expected length of stay that is less than 2 midnight. So they're saying they will allow for case-by-case exceptions. There may be times when, well, I don't think they're going to stay 2 midnights, but I still feel like they need to be taken care of in a hospital. And I kind of was thinking, Kendall, about, that case that we had recently of that young gentleman who had the very severe hyperglycemia. He was in ketoacidosis, and he got better that night, and they discharged him in like 24 hours. Which, whether that was a good thing or not, that's another conversation. But that's definitely one. You've got him in ICU on all kinds of drips.
On an insulin drip, and these are things, and we'll get into it a little bit later in the talk, where you may look at hospital bylaws for medication administration that require the patient to be in the ICU or to be an inpatient for administration of an insulin drip, nursing services, a lot of cardio active drugs to treat arrhythmias. You may expect a quick resolution of the arrhythmia, but the hospital policies or the standard of care for administering IV amiodarone, IV beta blockers, et cetera, may require the patient to be on an inpatient basis. So those are the case-by-case sorts of things that we look at. And as we talk through all of these, the one commonality to all of these things is going to be physician documentation. And Denise and I'll get into that in a little bit, because that's going to make or break all of these cases as they're audited and looked at, and they will be scrutinized very closely. So we'll talk about that in a bit.
Yeah, definitely. Okay, and then we have the 2 midnight presumption. The 2 midnight presumption really has to do with the fact that CMS basically has told traditional Medicare, you do not routinely audit for stays that are that cross 2 midnights. Okay, we're going to presume that the physician did the right thing and that they expected the patient to stay 2 midnights and they stay 2 midnights or whatever. So don't go back. You shouldn't be going back and auditing those. That does not apply to the MA plans. Now, the case-by-case exception applies, and the benchmark, 2 midnight benchmark applies to MA plans. The presumption does not apply. So just make sure that your teams are very well versed and understand these things. So MA plans can audit, and they will audit your 2 midnight stays, okay, your short stays. They are allowed to do that. CMS says that's up to the MA plan how they want to do their audit. Okay, the inpatient definition, don't forget this is how CMS defines the inpatient stay, okay? It's not only hospital care that spans at least 2 midnights, okay? They also have to consider other things, okay? It's the decision to admit a complex medical judgment can only be made after the physicians consider a number of factors, including the patient's medical history, their current medical needs, types of facilities available to the inpatients or outpatients. As Kendall said, hospitals' bylaws, admission policies, the appropriateness of treatment in each setting. They have to consider things like the severity, the signs and symptoms exhibited by the patient, The medical predictability, something adverse happening to the patient. And then there's actually a couple more bullet points that don't make a whole lot of sense, so I didn't include them on here. But it's not just 2 nights in the hospital. There has to be a reason for them to require hospital care. Okay. The Medicare Managed Care Manual, Chapter 4, and we're going to talk about this a lot, talks about how the MA plans have to have policies and procedures that allow for individual medical necessity determinations. Okay, so they have to make their medical necessity determinations based on what we just said: enrollee's medical history, their diagnoses, their conditions, their functional status, physician recommendations, clinical notes. So Dr. Smith and I were talking about this and how that plays into our pre-service authorizations, our authorizations for admission. When they're reviewing the case, are they considering the above? Are they considering the individual medical needs of that patient? And if not, this is where Dr. Smith recommends this is the time to do your peer-to-peer to help point out, that this is not, you can't just go off of one diagnosis that the patient's being admitted for. You've got to look at the whole patient.
And it's incumbent on the admitting physician or the physician taking the history to provide something more than a laundry list. Handling, thousands of denials a year, we see H&Ps that are essentially laundry lists of active problems, but there's no commentary as to how these conditions interact with each other, the complexity or degree of difficulty of managing them. And I think that's probably the biggest area of weakness we see in establishing medical necessity for inpatient care, is moving away from the laundry list determination to a full thought out paragraph that describes the age of the patient, the comorbidities, the interplay of comorbidities, the risk of mortality, et cetera, at the time of admission. So it's imperative that we get that documentation in the chart up front so that an appropriate pre-service authorization can be obtained and considered.
Okay, and then I also want to point out this prior authorization statement that came out with the final rule. So many of you on the call probably already are aware of this little sentence that kind of lives, or it doesn't kind of, it does live, in the Medicare Managed Care Manual, Chapter 4, under medical necessity, but it kind of lives out there on its own without a lot of context around it, where the statement is, if a plan approves the furnishing of a service through an advanced determination of coverage, it may not deny coverage later on the basis of a lack of medical necessity. So a lot of us or a lot of folks in the industry, I know, were kind of hanging their hat on that statement and trying to fight back with it to Medicare Advantage and saying, you gave us authorization to admit the patient. You can't come back now later and say, it's denied on the basis of a lack of medical necessity. But again, I don't think that really held a lot of weight with the MA plans. It was okay, if you have that in your appeal letter. I don't think it really caused a lot of denials to get overturned based on that statement. So what has come out in the final rule about prior authorization, and this has a little more meat and weight to it, is now that sentence has been replaced with, if the MA organization approved the furnishing of a covered item or service through a prior authorization or pre-service determination of coverage or payment, it may not deny coverage later on the basis of lack of medical necessity and may not reopen such a decision for any reason except for good cause. So, if they think there's fraud going on or whatever, they can reopen it. So that's a little bit stronger statement and a little bit clearer about what CMS expects from the MA plans. And so put this in your denial letter template. Okay, go ahead and put it in there now, and you'll have it after the 1st of January. And don't just put it in there, but make sure you're arguing it too as well. If you see this behavior, you need to call them out on that in your appeals process. Okay, documenting the need for hospital care. So how do you support the need for hospital care? Because that's what we're doing now. We've got to get away from the arguments that, well, outpatient in a bed is the same as inpatient in a bed. MA plans can't really argue that anymore. The bar that we have to reach is, did they need care that can only be provided in a hospital setting? Care that can only be provided in a hospital setting. Not, well, they could still be an outpatient and be in the hospital. No, if care can only be provided in a hospital setting and they stay 2 midnights, or there's an expectation they're going to stay 2 midnights, that's an inpatient. So we've got to readjust our thinking next year when we're dealing with the MA plans. And as we said before, consider your hospital policies for nurse staffing, for your drug administration, and for sure it is not custodial care. Okay, hospital care cannot be just custodial care. We talked about this quite a bit, Dr. Smith and I, about delays in treatments are not going to support that hospital care. So if they come in on a Friday with chest pain and you're waiting until Monday to do a cath, yeah,
that
not going to cut it.
Not going to cut it, no.
Yeah. So as Dr. Smith said, don't document a laundry list of problems. It really is going to come down to, as it always does in denial of appeals, the documentation in the record. Do document the risks and immediate concerns regarding the holistic picture of the patient's acute and chronic medical conditions. And we call that connecting the dots. You really have to spell it out to say, this is why the patient needed hospital care. Connect the dots between what's going on with the patient and why they need hospital care. All right, so a couple of things about MCG and InterQual, and I know Dr. Smith wants to talk about this in a little bit more detail. So MA plans have to comply with general coverage and medical conditions included in traditional Medicare. Okay, so that's what CMS has clarified with this final rule, including payment criteria for inpatient admissions. They cannot use InterQual or MCG criteria or similar products to change coverage or payment criteria that's already established, like Dr. Smith said, NCDs, LCDs, other published coverage criteria. The MA plan has to use that. They can't say, no, we're going to use MCG instead. They can use MCG, they can use InterQual, they can use those screening tools to help them determine whether or not they're going to approve or authorize payment for services, including admissions, but they can't use them in isolation without compliance with requirements that are published in the final rule. Okay, so they can't just say, we're just going strictly by MCG, we're going strictly by InterQual. We're not going to consider whether they need hospital care for 2 midnights. We're going to ignore that and just go by MCG. They can't do that in isolation. Okay, Dr. Smith, you want to talk about MCG and observation a little bit?
Yeah, so this was an interesting discussion that came out from Millman, from MCG, in the context of observation. Specifically saying the duration of observation care is often determined by prevailing regulation. The 2 midnight rule is an example, or maybe defined contractually between the hospital and the payer. When writing criteria pertaining to observation care, it's helpful to have a general duration in mind. And this I found to be really telling. MCG feels that appropriate use of observation care necessitates that observation care should be finite, short, and not mandatory, i.e. it's not necessary to put somebody in observation first who clearly needs inpatient, have them fail observation, and then put them inpatient. We've seen that come back a lot with patients who came in with respiratory failure, were intubated in the ER, moved to the ICU, and the care was denied because they hadn't failed a trial of observation prior to being moved to the ICU. So it's, there are some absurdities around it. The telling thing here is keeping with our understanding the definition and purpose of observation care, which is a decision-making process. I liken it to purgatory, where we're going to hold you there to decide whether you can go home or you're going to need to come in the hospital. It's a short, finite period of time. It's not meant to go on 5, 7, 10 days, as some payers would have us believe. Rubrics such as the 2 midnight rule provide a good estimation of what is meant by the word short. Millman's view, MCG's view, is that the 2 midnight rule is a good rubric to keep in mind. Timeframes beyond this, 3 days, 72 hours, are not what MCG envisions for observation care. So directly from the horse's mouth, very telling. I think he comports well with what CMS has put forth with the 2 midnight rule. Something to probably keep in your toolbox and be able to push back with when payers are denying inpatient on long observation stays. I just looked at a inpatient stay that was 9 days today, denied using MCG with the argument the patient could have been kept in observation. It was not a custodial case. It was a case, Medicare Advantage case. The patient was actually getting active treatment for an infection during that period of time. And the payer pushed back and said all this could have been arranged in a lower level of care. So keep that in your back pocket. You may want to pull it out, but it is a good reminder as to when to push back and how absurd some of these things are getting. Move on to the next one, Denise.
Yeah.
So what's a reasonable attempt in observation care? I think ultimately as a physician advisor, you know it when you see it. MCG's come out and said that we can't define every clinical scenario to say whether this was appropriate or not. There should be a reasonable, a good faith attempt to improve the patient's condition with appropriate treatment. Patient with COPD coming in, getting nebulizer treatment, dose of antibiotics, some steroids, and then a period of observation of several hours to see whether they're going to break or be able to go home. It's not appropriate to drag this treatment out for 3-4 days waiting for them to resolve. Observation is just that. You go back to the original definition of it, the holding pen, to decide whether the patient needs to come in for ongoing treatment or whether they can safely be discharged home. So I think the important thing is that you're working in good faith during that period of time, treating the patient, and then at the end of a period of time, it doesn't have to be 2 days. It may be very obvious after the initial round of treatment that the patient's continuing to deteriorate. Their lactic acid, procalcitonin levels may go up, their blood pressure may continue to drop. They've failed treatment, they need to come in after 8 hours. Let's admit them to the ICU as an inpatient at that point. You made a good initial good faith effort to treat them, not happening, let's admit them. But when you do that, and this is an Achilles heel that we see in a lot of records that we appeal, we can go back and we can piece together what happened from orders, from nursing notes, etc. But very rarely is a physician actually coming into the chart and saying, I am admitting the patient as an inpatient now because, fill in the blank, they've worsened despite initial antibiotic therapy, fluid resuscitation, their mentation is worse than when they got here. Therefore, inpatient care is now appropriate. So many denials could be prevented if we could get the admitting physician or the ER physician, the end of the observation period when that inpatient order goes in, certification is signed electronically, just to give us a little brief color commentary as to why you're giving up on observation and why they now need inpatient. That would go just thousands and thousands of yards to getting these things overturned up front. If we could highlight that, send it back to the payer and say, listen, this was the thought process. This is what was going on clinically. This is why you're wrong, that observation should not have been extended. Move on. And I think we talked about this. Do you have to cross 2 midnight, get up to the second midnight in observation before transitioning them? No. Ultimately, it's a clinical call, but it's a clinical call that needs to be supported. And I sound like a broken record. Needs to be supported with clear, concise documentation and clinical thinking. At that point, it could be 4 hours, it could be 6 hours, it could be 18 hours. They can be moved to inpatient. It doesn't have to go right up to just before the 1 minute before the second midnight to happen. Document, document, document. And I think it's going to be the biggest challenge that folks on this webinar are going to have moving into 2024 is working with key stakeholders in the ER, your admitting physicians, to help them understand the necessary documentation to denial proof charts.
Okay, so we did a little, actually Dr. Smith did a little research on some of the top payers and what have they published thus far in their plans to change anything, any of their behaviors or the way that they operate starting after the first of the year. So we only found
there was a lot of hope originally when this got published. Gosh, everything is going to be like traditional Medicare. We order 2 midnights. They're going to leave us alone. You know, there's going to be the benefit of doubt is going to exist here, that they're not going to come crawl up our undies and look at these cases. That was probably a little too Pollyannish and too hopeful. Humana, United, we'll look at United especially here, have actually, United seems to push the boundaries a little bit beyond what CMS said. But Humana, and they're well within their rights to do this according to the final rule, that healthcare providers should always assume that Humana Medicare Advantage plans, I would say will review, not may review. They will review a claim for medical necessity, especially anything that's 2 or 3 days. They're going to come back and look at the medical necessity of that case, independent of whether the case was in the hospital 2 midnights or not. And we do see a lot, you know, in defense of the payers, and it's rare that I would rise the defense of some of these folks. We do see a lot of cases that end up being denied, where the patient, as Denise mentioned originally, came in on a Friday, and surgery couldn't be planned until Monday. And is that truly a 2 midnight stay at that point, where you're getting 3 hots and a cot waiting for a surgical procedure or cardiac catheterization while you're on heparin for 2 days, when that procedure should have been done that afternoon or the next morning. So, I think they're within their rights to do this, provided the policies that they use, the guidelines that they use, are all they all comport with Medicare's rules and guidelines. What we're seeing with United, I think United's the next one, isn't it, Denise?
yeah.
Yeah.
So United, in their policy, they basically just quoted, what CMS says, expectation of hospital care that requires, or that they expect is going to span at least 2 midnights, used as a benchmark, whatever. But then they went on and added this statement at the bottom that says, for coverage to be appropriate under Medicare for an inpatient admission, the patient must demonstrate signs and or symptoms severe enough to warrant need for medical care, must receive services of such intensity that can be furnished safely and effectively only on an inpatient basis. And that is not part of the CMS guidelines. So yeah, they said, oh yeah, we're going to parrot exactly what CMS says for traditional Medicare, but we're going to have a couple other statements in here as well, or I guess this is one statement, one sentence, but that's not it. That's not part of the CMS guidelines. So yeah, I would just be on the lookout for that. You should be reviewing now your top payers to see what they've published about how they're planning on operating under this newly affirmed, guidelines from CMS, and be on the lookout for this to happen and push back when it does. Okay, and then we also had another something else about United Healthcare. I think Dr. Smith, this was something you put in here for us to talk about.
Yeah, they're going to continue to use InterQual, given that they purchased it about 2 years ago. They've set forth, and there's some documents or some links that I think are at the end of discussion that you can reference yourself. One called Elective Inpatient Services, that will give a detailed explanation of what they consider inpatient hospital services. And these are things generally on the inpatient-only list, but there's an explicit 4-page document from United. There's also a hospital definitions clinical criteria policy that's available under the hospital services observation and inpatient document. And I believe the URL is at the end of the talk. If not, we'll get it for you if you want to download and read that and have an understanding as to how United Healthcare is going to look at it. We talked about early on peer-reviewed journal, peer-reviewed evidence, and other sources of medical evidence to support medical necessity. United's come out and said we're going to use InterQual as a source. It may not be the only source, but they're going to continue to use InterQual. And this is what I found to be interesting, to be used in connection with the independent professional medical judgment of a qualified healthcare provider. That's open to a wide latitude of interpretation as to how that's going to come out. So stay tuned. We'll see what the letters start to look like. I personally don't believe that the denial letter is going to change substantially from December to January, but we shall see.
Yes, and we do have on the slide deck, the last like 3 or 4 slides are all of the links, because what I do like to do is leave you with the ability to go back and look this stuff up yourself as well. I know that's just one of my things, that it's great for people to tell me something that I may not remember or may not understand it completely. If I go read it myself, it makes a little bit more sense, or at least, helps it stick in my noggin. Let's talk about the inpatient-only list a little bit. So this is, hopefully, if you're already involved in doing or scheduling procedures, you're already well-versed in this. But I just wanted to mention it as well. I've got links here for how to find it. In my opinion, it's not easy to find. They update it and publish it every year at the end of the 3rd quarter. I always have to hunt around and look for it, but it only comes out once a year, and I forget where it's located. There may be a shorter way to get there, but this is how I find it. It's in the OPPS outpatient prospective payment system update that goes out every year, as I said. We'll download as a zip file once you get to the end of this long series of links to get there. Open it up, the zip file up. You want to save addendum B. There's addendum B and there's addendum E. E is an elephant. And the reason I say addendum B, this is a snippet from addendum B. Addendum B will give you it's called the status indicator, SI. It's like the 1, 2, 3, 4th column there. And the status indicator will tell you whether it's an inpatient procedure or whether it's a Part B service paid through a comprehensive APC outpatient service. So when you look at addendum B, you're going to get total hip arthroplasty on there twice. Once it's paid through a comprehensive APC as an outpatient, and once it's paid as an inpatient. The difference between the two, they have different HCPCS codes. One is a total hip arthroplasty, the other one is a revision. So you have to be very, very careful. You can't just look at, it says total hip arthroplasty and there's a C, which means it's inpatient, we're good to go. You really need to know what the HCPCS code is. So if you open up addendum E, you will get only a list of HCPCS codes and short descriptors that have the status indicator C on them. So pick which one you want to use, but addendum B gives you a little bit more information. And if you don't know what the status indicators mean, you can open up addendum D1, and that will give you the status indicator. So a little bit of putting the puzzle together there to read it. But hopefully you've all you're going to have your ducks in a row by January 1st, and make sure for your Medicare Advantage plans that you're following the same process for making sure that your patients are in the correct status when they come in for surgical procedures, as they should be, same as for traditional Medicare. So I know, go ahead.
Sorry, Denise, there may be situations, patient coming in for an outpatient procedure, if something happens intraoperatively, they may come in for a lap chole, for example. It's converted interoperatively to a open cholecystectomy or some other procedure on the inpatient-only list, it's appropriate to admit them, write that inpatient order after the procedure. So you may start in an outpatient setting with an observation order, an outpatient order on the chart, but it's really key to keep track of what was actually done during the surgery and make sure that you don't cross into the inpatient-only territory as a result of sort of unplanned adventures intraoperatively that do result in something landing on the inpatient-only list. If that order is not admitted by the time, if that order is not on the chart by the time the patient's discharged, it can't be recouped later, and that's sort of a never event that you want to try to avoid.
Yeah, good point. Okay, so I know there's probably a dozen questions in our questions box already about contracts. So, hey, I have a contract, and my answer to that is, what does your contract say? What's in your contract? So yeah, look at your contracts and see what they say. I seriously doubt that any or many of your contracts are going to talk about how, whether or not they follow the 2 midnight rule or whatever, but there's probably something in there about how they audit, how they'll be doing auditing. So, your contract is going to rule. You need to know what your contract says if you're contracted with these MA plans. And we know we've been seeing, in the news, a lot of hospitals are getting out of managed Medicare contracts. They seem to be smaller hospitals with smaller markets anyway, where there's not a lot of competition with other hospitals in the area. But just something to, something you got to think about as well is what does your contract say? What do you want your contract to say? What are you gonna have in there, the next time you do your contracting with that payer? And I'll just leave it at that unless you've got anything you want to add.
No, devil's in details. So by all means, sure that they are adhering to the contract. It's, I think, a good idea. You don't need the rates, you don't need a lot of the language, but if you have if you can make yourself a cheat sheet or a crib sheet of the audit requirements under the contract, as Denise mentioned, and keep those at your fingertips, you can make sure that they are complying with the contract and not going overboard with it. The same relates to timelines for responses. Quite often you'll have third-party auditors acting on behalf of the payer. That doesn't excuse them from adhering to the contract that's in place. We found third-party auditors both exceeding the contracted agreed to limits in terms of the number of charts that could be looked at, but also setting their own timeframes as to if we don't hear from you by this date, we're going to consider this resolved in our favor, sort of thing. And that's language that's nowhere in the original contract. So it's important to understand those, and by all means exercise your rights under them.
Okay, so the last thing we're going to talk about is what do you do when you identify noncompliance with the final rule, noncompliance with MA plans following the final rule. I want to point out a couple of things from American Hospital Association. So they have been, obviously, they're advocates for our hospital systems, and they have already filed a couple of notices with CMS about this particular topic. In October of this year, they sent something to CMS urging them to conduct a rigorous oversight of monitoring of the compliance of MA plans. They stated that one plan recently issued guidance to its network providers indicating that they plan to continue using internal criteria beyond traditional Medicare criteria to evaluate inpatient admissions. I don't know which payer that was, but we were just talking about one that had added some additional verbiage to their inpatient criteria. In other cases, it appears some plans are making changes to terminology they use in denial letters that may be intended to circumvent recent CMS rulemaking. So they're calling them, when they audit cases, they're not calling them patient status audits or level of care audits. They're calling them payment reviews. They're calling them billing validation audits, all kinds of crazy things, so that they're trying to get around saying we're auditing for the medical necessity of the admission. We had a newsletter on that in June of 2023. If you're an Atom member, you can go into the newsletter area of our website. After you log in, you can read that newsletter. This was brought to my attention by one of our Payer Watch clients, as well as others out there in the community who contacted me and others about this particular practice. And it's one of those, I'm just shaking my head, can't believe that, that they would do that, but they did. Hopefully they've stopped that practice, but maybe not. And then also AHA said to CMS, they said we're requesting you to clarify, and reinforce. Well, that's what CMS is trying to do with the 4201 final rule. But the one sentence I thought was good on AHA was they were asking CMS to take swift action to correct MA plan policies that don't comply with CMS rules, including applying intermediate sanctions where appropriate. So they're really pleading with CMS to be the police in this scenario and to act swiftly and make sure that they are applying whatever penalties are appropriate for MA plans who don't want to follow this. So that's another avenue of advocacy for hospitals, is to work with the AHA if we continue to see widespread non-compliance with this rule. Other ways you can respond: you can file a grievance with the plan, you can submit your experiences to the Part C and D mailbox. That's there more for answering questions about how MA plans and how they're supposed to operate. But you can certainly sometimes get some action or get some feedback by sending an email to the Part C and D mailbox. You can file your concern with your CMS regional office. I have the link there where you can find your regional office. I think that's a good way to go. I think you will get response from the regional office. At least this is what I've heard from those in our community who have done that. Make sure you're tracking your cases and discussing those if you're having joint operating committee meetings with your plans, or take it to the plan's medical director. You can also get the enrollee involved. You can get the patient involved especially if you've got a patient who is kind of interested and astute in doing that kind of work. You can ask them to call 1-800-Medicare and they can complain. And Medicare actually will, in my experience, my opinion, they give more weight and more attention to enrollees who are not being treated fairly by the MA plan, more so than the hospitals. So if you can get your patients to complain, that's a good way to go as well. Anything you want to add to that, Dr. Smith? Okay.
I think you hit it spot on. Anytime you can get an enrollee on the phone with Medicare, you're going to have a much better outcome. It's surprising some of the stories that have come back from those experiences.
Okay, so some of our takeaways, just a reminder that the MA plans have to cover inpatient admissions that fall within the 2-midnight rule and the case-by-case exception and the inpatient-only list. They can still audit the claims for inpatient care lasting more than 2 midnights. The contract between the hospital and the MA plan governs those audit rights. The provider should ensure your documentation practices continue to adequately support the medical necessity of the hospital services. The final rule provides hospitals with a strong argument. Inpatient care that lasts at least 2 minutes should be paid under Medicare Advantage as it would have been under traditional Medicare. So these are the things you need to be doing over this next month. And after the new year arrives, ensure your teams understand the 2-midnight benchmark, the case-by-case exception, the 2-midnight presumption, which that piece does not apply to MA plans. Make sure your documentation is connecting the dots to support that hospital care. Don't allow MAOs to use screening tools in isolation. Know your payer policies and review your contracts. So look up your top 3 or 4 or 5 payers and see what they're publishing as far as how they're going to be operating in the new year. Your surgical make sure they're including MA payers in the reviews for inpatient-only procedures. Consider incorporating the prior authorization language in your appeals that I had on the prior slide, and make sure you're reporting noncompliance with the final rule. And of course, we're going to be here and available to help you if you have questions. If you have experiences you want to share with us, please let us know. We're going to try to do probably do a follow-up webinar on this in the early late winter next year to kind of share what we're hearing from the community, what we're seeing, and what's going on with this change in plans. So let's see, got just a few minutes left. I'll just see if there's a couple of questions we can answer. I haven't looked at the questions box. I'm not sure how many we've got. Let me pop this out, make it a little bigger so I can actually see it. Does CMS further define hospital care since they don't use screening tools and criteria? And that's a really good question. And I think, to me, that's kind of the crux of some of what we're going to be dealing with after the first of the year. Is how do you define hospital care? And again, it's very difficult, just like MCG saying, you can't like just talk about every possible scenario of patient care and say this is hospital care, this isn't hospital care. It's not that black and white. They're really just saying it's care that has to be provided in a hospital. I didn't say that correctly. Care that can be, that, I can't remember how that was worded now. I'm talking about it. Care that can only be provided in a hospital setting, I think is the exact wording. Care that can only be provided in a hospital setting.
The totality of the services offered can only be offered in a hospital setting. You may be able to get IV antibiotics set up for somebody at home, but if you couple the need for IV antibiotics with Q1 hour neuro checks because you've got a patient with acute metabolic encephalopathy or something else going on, it's the totality of the services that are being offered that equate to the need for quote hospital care. If you break hospital care down to its individual components, a lot of the components can occur in a rehab setting, an at-home setting, an ambulatory care center, even an observation. I think it's the compilation of everything that's going on in total that leads to the concept of hospital care.
And somebody asked, said that made a statement that Aetna has said that their MA plans are not required to follow the 2 midnight presumption. That's correct. The presumption does not apply to them. Okay, so I think I explained that pretty well, and you can go back over the slides again. They do have to follow the 2 midnight benchmark and the case-by-case exception. The presumption has to do with auditing. And no, they do not have to follow that. They can audit however they, have in your contract or whatever audit practices they have in place that help them with managing the cost of the care that they provide to the beneficiary. Does the care over 2 midnight need to be appropriate, and what defines appropriate? Oh yeah, I would say it needs to be appropriate to take care of that patient, but again, it just has to be care that can only be provided in a hospital setting. Okay, and I think we're going to have a lot of discussion over what does that mean.
You can't take somebody with a hangnail and say that they're going to need 2 days of care and make them an inpatient. There's just not the severity of illness that exists with a hangnail. If that hangnail belongs to a patient with uncontrolled diabetes, severe peripheral vascular disease, who's coming in with gangrene, completely different scenario, but the devil's in the documentation then. So we get back to documenting the medical necessity of why they're there, why they need to be there 2 midnights. The idea of admitting somebody on a Friday saying they're going to need 2 midnights for something that's going to happen on a Monday, not only will Medicare Advantage come back and crawl through those cases, but eventually the OIG or Medicare themselves, CMS themselves, will start to look at those outlier cases because you're going to have a lot of outlier data points as compared to other peer groups for weekend stays, short weekend stays, and those are going to be open to audit. It may not be the RAC doing it. It'll be some other Medicare agency that's coming back after those. And in that case, you know, the presumption does not exist because the care wasn't needed. They were just waiting for services that weren't available.
Okay, well, that brings us up to the top of the hour. I want to thank everybody for attending today. There are a lot of questions in our questions box, and like I said, we will do our best to try to get those written out and answered in written format and published on our website within the next couple of weeks. So just give us a little bit of time to do that. And thanks, everyone. Enjoy the rest of your day. Enjoy the rest of your year. We'll see you after the first of the year. No webinar in December. Please consider signing up for our end of January virtual winter workshop that we're going to be hosting. And we will see you after the first of the year. So thanks, everyone.
Thank you.
Thank you, Dr. Smith. Appreciate you.
Peace. Thanks, everyone. Bye.